Thank you. I think your talks are very sobering. Everyone is looking at all the problems we have. So next up is from the pathologist perspective. We have Dr. Michael Cohen, who's the chair of pathology at Wake Forest School of Medicine. Dr. Cohen.
All right, thank you all. As you'll see, there's probably going to be a lot of overlap between Hetty's comments and mine, and perhaps predictably so. So this is my only disclosure. So about 100 or so years ago, I think Osler recognized that pathology was really at the nexus of most excellent patient care. I think the heyday of pathology's recognition has passed that, but I think it still remains an incredibly important underpinning in the care of any patient, and obviously it is germane today in patients who have cancer. Now, this is sort of my starting point here, and this is based on Atul Gawande's, one of his many books. And I think people will recognize that errors do occur, but I guess it's more in the context of what type of errors occur. And I think this is something that was brought up in the 2015 report that Hetty has referenced a couple of times. And I think some of the errors are preventable, some of them perhaps less so. So the focus of my discussion is based on anatomic pathology, which is either based on tissue or cells. There's a whole other aspect of pathology, which is in the clinical laboratory, where we're largely focused on blood and other body fluids in things like chemistry, microbiology, and the like. And obviously, in anatomic pathology, we make great use of so-called ancillary studies, which cover the gamut from protein expression to specific DNA and RNA abnormalities. And this is a rapidly changing field. NGS is sort of all the rage now. While it's viewed as fairly objective, I think there's room for more objectivity, particularly in some of the algorithms that are used. At the outset, I wanted to take a step back that even in 2018, I think there's still value for the autopsy. The national autopsy rate has dropped dramatically, but in this study, which was published just at the end of last year, you will see that there are still about 20% of cases where errors are identified, which would have varying degrees of clinical impact that were identified with this procedure. And my guess is nationally is the autopsy rate is probably under 5%. And I think as we move forward, we need to refocus on this because at some level, this can be viewed as the ultimate biopsy. So what is the error rate in anatomic pathology? So there's a whole litany of articles out there. This is one paper which estimated a range anywhere from 1 to about 6%. It becomes complicated because it depends on how you define error, what the anatomic site is. But, the ballpark figure is probably in the range of 3%. And just at the bottom of the slide, just to put this into context, if we got the error rate to 0.1%, this is what would happen in other aspects of our lives that we're familiar with, which is clearly unacceptable. Whether we can even attain a 0.1% error rate, I don't know, but I find this a very humbling series of statistics. Here's a specific study that was done a decade ago at an academic health center. This is second opinion. These are then cases where patients have had their biopsy or some pathology material in a community setting that is then re-reviewed centrally by so-called experts. And you can see that the major diagnostic disagreements are about 2.5%, and this is cancer versus no cancer, and that there was also very significant minor disagreements, which focus on things like staging, margin status, lymph node involvement, and the like. And the common sites, at least in this study that were identified, are listed here on this slide. There's some other data. I think Hetty referenced some CRICO data as well. Pathology accounts for a fairly significant number of claims, as does radiology. And so this is a cause of concern, because I think, without trying to be too self-serving about this, the real triage point in the management of patients with cancer really rests with pathology, and an accurate diagnosis is critical for that. The Doctors Company has also provided some data that you can sort of see summarized here. The hot areas seem to be lung, colorectal cancer, breast and prostate. In a different era, gynecologic cytology was a particularly important area. That's sort of fallen off a bit. But certainly in the current climate, breast and prostate biopsies are a real hot button, as are melanocytic lesions of the skin. So, a melanoma or melanoma mimics. Now, I think one of the real complexities in all of this is in the area of so-called molecular diagnostics. Dr. Brawley references Oncotype DX, which is clearly a very important test that's part of the NCCN guidelines. The challenge that some of us have with that is it uses a proprietary algorithm in order to arrive at its determination in stratifying patients at risk who are, ER positive and HER2 negative. And therefore, the ability to replicate that becomes very difficult. And this is just one example. There's sort of a bevy of new startup companies coming out that have all of these proprietary tests in terms of how they determine things. And it really ultimately comes down to how the bioinformatics analysis is applied. And there is, in truth, an element of subjectivity in all of this, because there have to be some cut points that are determined. But to a large extent, this becomes very opaque. This is quite different than if you're looking at a specific mutation, such as KRAS. These are obviously large-scale types of analyses. And there are obviously a number of ones that are out there. Foundation One now has an NGS test that they're trying to get a national coverage determination for, which is a cause of great consternation in my field, at least. But clearly other companies are out there that are offering any number of types of molecular diagnostics, precision medicine, if you will, that I think need to be taken into account. They clearly add value, but I think they need to be incorporated very carefully. So what are some potential solutions? So the College of American Pathologists and the Association of Directors of Anatomic and Surgical Pathologists, they made a number of recommendations, which you see here, including developing robust quality control measures in order to do this. One example that might be incorporated would be mandatory second review of all new cancer diagnoses. The challenge with that one is patients who do not have an initial diagnosis of cancer may therefore have a delay in diagnosis. And obviously, having two pathologists read every pathology specimens is just impractical. And so on that spectrum, there's going to have to come a more refined and nuanced type of approach to things. There is a new staging system that just took effect about a month and a half ago. The CAP has specific cancer protocols which require inclusion of all the elements in order to comply with the staging system, although they are not uniformly applied. And how you would mandate that, I think, is an open question and a cause of concern. So I wanted to make the analogy, as I did before, about what we might learn from other industries, in this case, the airline industries. So when I do my work as a diagnostic pathologist, I'm in my office, but I am not locked in like an airplane pilot. The door is not closed. The phone still rings. I may still get a text message. I may still be paged. My full cognitive attention isn't always on the work that I'm trying to do. And I think there's something to be learned from here. Referring earlier to Atul Gawande's book, obviously, there's a very elaborate checklist that pilots go through before takeoff occurs. And if there's a way of adapting that to pathologic and perhaps radiologic analysis, I think we could move forward significantly there as well. And then finally, moving forward, mention has already been made about artificial intelligence. This is a very recent paper coming out of, I believe, the Netherlands, where they used some sort of sophisticated computer-based analysis looking for lymph node metastases in women with breast cancer, and show that there was relative comparability between the gold standard of pathologists. And so obviously, this is an opportunity. I think it's going to be a challenging one, but I think there are many activities that pathologists take part in when they analyze images under the microscope that could certainly be automated, or mechanisms could be put in place to help and facilitate that analysis. So my final slide here is that there's clearly a lot of overlap between pathology and radiology. And, so one of my harebrained ideas is that, as these molecular reagents become more and more sophisticated, the distinction between pathology and radiology, I think, is going to narrow. I've seen data at one of the institutions I worked at where you could get almost microscopic level images of lung if you use a high enough radiation dose. Obviously, that's not tolerable in the clinical setting, but you can get down to the alveolar structure with enough with the right technology. But I think in principle, that's something that can be overcome. At the same time, pathologists often use things like immunohistochemistry, which are antibodies targeted at identifying certain proteins either on the surface of cells or inside cells. But in reality, there's no reason why these couldn't be adapted and introduced intravenously, and therefore you could have, very sophisticated imaging and diagnoses that's done in vivo, and the need to have a piece removed from the patient might disappear. So I'll leave you with that thought to ponder, and I'll thank you for your attention.